Hi, all. Thanks so much for watching Making Healthcare Work for You, Different Perspectives and Empowering Solutions. I'm Stephanie Fields, joined by my co-host, Dr. Apoorv Gupta. And today we welcome Dr. David Nace, who is the Chief Medical Officer at Innovaccer, and Dr. Glenn Steele, who is the co-chairman of the advisory board at Innovaccer and also the former CEO of Geisinger Healthcare System. Thank you both for being here.
Great to be with you, Stephanie.
Looking forward to it.
I'm really excited to talk to both of you about a couple of things. In our pre-interview, we had a couple different streams of thought. We talked a lot about payers and providers, about the importance of primary care and really relating to the patient. We talked about AI, and that's obviously something very important to Innovaccer because you guys are providing data around these things, and you've partnered with Upstream, who is a partner of ours. And so why don't one of you take it away, whoever wants to start first, about this partnership, what Innovaccer does, and then the partnership that you're doing with Upstream, how you feel like this can transform healthcare as we know it right now.
Sure, I'll start with that. So, Innovaccer is a data company. One of the biggest challenges in healthcare is you can't manage what you can't see and understand. You need data to do that. And you need data from a multitude of many sources. Data is often complicated, particularly in healthcare. It's why healthcare has been the last industry to really transform. So how do you bring together data from multiple places? How do you connect the players in healthcare so they can work together off the same page? And how do you generate insights with these modern techniques like AI and put them into workflow so people have an insight when they need it, it's actionable, and they're all connected so they're working together again off the same page? Upstream has been a interesting customer of ours. They're a part of the newer, innovative primary care focus groups that's using tech platforms, in this case, Innovaccer, to really move forward to taking full risk for the patients that they manage, and then integrate things that haven't been so integrated before, like the role of a pharmacist in a physician practice. How do you get to many different small practices working together and collaborating to take care of a particular population? And how do you manage the risk? Be fully accountable for the results you get from those patients.
Dr. Steele, I don't know if you wanted to jump in when we were talking earlier, when as David had talked about the data piece. I think you had some very insightful thoughts about the relationship piece as well. And obviously that's critical to primary care transformation. So maybe that's a good place for you to jump in with your thoughts about how the data gets extended, into that arena. And then the artificial intelligence that David also mentioned, how does that get wrapped into the equation? So we're delivering excellent care, not only in the direction that we need, but also supported in the kind of interaction that's appropriate.
Yeah, well, the two strategic foundations that, gave us the ability to do what we did when I was at Geisinger were the following. The first was payers and providers working together to the benefit of their mutual constituents. And that was remarkably different than, payers and providers beating up on each other. And the key enabling of that working together was data that was transmitted between our payer and our provider, and our provider and our payer. And at the time when I was at Geisinger, we had commitment to Epic as our EHR, which was great, except I had about 150 FTEs that were trying to make Epic functional for our providers. And if Innovaccer had been around at the time, it would have been a lot easier for me. The second strategic foundation was the ability to use our primary care, which is spread out over 47 counties in Pennsylvania, as the leverage point for creating long-term relationships between our providers and our patients, whether our patients were on the payer side or whether they were patients seeing our providers. And my life after Geisinger has been to see whether or not that could be scaled into other environments. We had many advantages, obviously, in central Susquehanna that are probably not easily scalable. And my attraction to Innovaccer and my attraction to Upstream and organizations like Upstream is to use the enabling technology and to use the scaling ability of companies like Upstream and other companies in order to enable the primary care physician to be the quarterback for, long-term relationships that, when people get sick or when they're trying to stay healthy, are really the most important and effective combinations, whether they need to be referred to specialists or subspecialists, what have you. So these two fundamental strategic foundation points at Geisinger have led to kind of the scaling exercise that I'm involved in with Innovaccer and with Upstream.
It's really fascinating to me that you started your career as a surgeon in cancer. You said 45 years ago when that specialty was just starting. So you were on the cutting edge of what was happening at that point. And you realized then the quarterback analogy that you were just saying, that you became that central point for your patients, and they're looking at their health holistically and guiding them through things. And then you moved on, you ended up at Geisinger, had incredible transformation there. And now in your role in Innovaccer, you're still doing something incredibly innovative with the AI, but you're still connecting that to the human relationship. And David, you said the same thing, that it's the human relationship that's important, and the primary care, that's what matters. So it's a fascinating dynamic that, as cutting edge as AI is in all the different ways, that this human perspective or human connection cannot be separated from it. You still have to have that. So it is still a partnership, in the way that I think how you were saying payers and providers were always at odds. And I think people think of that like it's AI or humans, but they're not at odds. They're also a team and have to work together. So whichever one of you wants to take that, what do you think about that? How important is that human perspective behind AI, and how do you use that to connect the dots to provide the best care to the patients and give the providers the best information?
Yeah, I first went into family medicine because I grew up in the 60s. I used to watch Marcus Welby, MD, and this role of a very trusted, caring person who knew the community, was representing the community, and really knew the families. We go into the homes and understand, how they're doing as a family from an income perspective, how they're getting together. The other piece is, since the beginning of civilization, the role of the medicine man has always been a trusted entity in every civilization. It's almost seen as a spiritual part of the community and human endeavors. So I think, this role of a trusted relationship, really a guiding relationship, is key. Now, we've made a lot of efforts in technology, and we have AI, and some people say AI may be the greatest threat, that we face. I would say, when I hear this phrase that AI is going to replace physicians, I was going to say that's just not going to happen. But what will happen is physicians who use AI will replace physicians who don't use AI. And that's where the trusted relationship, it's a tool.
Yeah, the other thing is, there's an awful lot of healthcare that can be commoditized. I mean, when I say that, that offends most doctors, and particularly of my age. But I'll give you an example. Management of hypertension, which if hypertension management were optimized, we'd probably have more effect downstream on outcome than just about any other aspect of healthcare in this country. It's different, in other countries, but in this country. And what we found at Geisinger, and what, I think can be scaled through re-engineering of primary care, is how hypertension is managed. I mean, in the early days, when I had a primary care physician and my systolic blood pressure was high, I would get a lecture. It would be about a 2-minute lecture, and I would be sent away, and I'd come back a year later, and I get the same lecture, basically. And what we found, and what others have found, is if you have other people giving the information to a patient in a consistent way, and having the patient built in, with a lot of devices that weren't available when I first started to relate to my doctors, you get a lot more response and a lot more optimization of blood pressure management, and that frees time up for me to talk to my doc about whether I should have a PSA or not. And, and that's, that blood test and whether or not I should have it at my age is not, it's not an easy kind of a recommendation. But I want my primary care physician to understand, who I am, what my values are, and take that into consideration when he or she mentions whether I should have that PSA as a screening test for prostate cancer. So it's really a redefinition of who does what. And I think AI and social media and a lot of devices that are now available can help us optimize a lot of the commodity aspects of healthcare.
Glenn, you've really touched on a really important point, and it really relates to the title that Sanjay Dudamani and others at Upstream have given the name to the company, Upstream. So we've learned a lot, and we talk a lot about the social, environmental, and economic impacts that have a much greater impact on a person's life and their health than medical interventions, which chagriningly, we found out has very little compared to the total world of the social determinants of health. And, our friend, David Nace, who's on our advisory board, often says we have to stop mopping up the floor and go upstream and turn off the faucet. So hypertension is a great example. I know in primary care, many patients that when they're focused on how do you exercise more, lose more weight, change your dietary habit, if you have a company like Geisinger, who's created a pharmacy with an F, a food pharmacy, and start to take data and track and measure and help to find ways to change the behavior, coach the patient, you can suddenly find that their hypertension will largely often disappear without medications, or you're able to wean them off their medications. So this is part of the piece about really addressing and understanding the patient and all of the environment that surrounds them. This is such a critical piece, and having the trust to be able to engage in those efforts.
No question about it. And, I've come to believe over the decades that I've been involved in healthcare that innovation is not the weak link. I mean, there's a huge amount of innovative stuff out there, and both in academic settings and in IDNs and in private practice, there's a lot of individual innovation. The real question is how you scale, and scaling is much, much harder than innovating. And that's what turns me on. And by the way, scaling doesn't happen unless you have a sustainable business model. I'm sorry. Yeah. And that's why in this phase of my life, which is dealing with innovative startup companies and whether you're talking about Innovaccer or Upstream or the other companies, it's a worthy experiment because scaling is hard and it is a worthy experiment. And if we just have little Geisingers around without scaling, we haven't really transformed healthcare.
Amazing. I love the way you folks are connecting all these ideas and starting to see that, how and a tremendous use case for Innovaccer and Upstream together that David, you just kind of laid out. I guess my question back to you on both on that point is, are you starting to see that with the use of these tools and with the emergence of these companies, are you starting to see any evidence of such scale or transformation happening that's giving both of you hope that, yes, it is possible using these technologies and new approaches?
I think the externalities are demanding the change that we're talking about. And a good example is not just ACA and what was built into ACA, but a continuing move to shared risk, value-based care, continuing pressure on hospital-centric business models, demographic shifts where the men and women who are actually giving the care actually expect to live a reasonable life, not sacrifice everything else in their life to their profession the way it used to be about 40 or 50 years ago. So I think we have a forcing function that is absolutely pushing us towards care moving out of hospital-centric facilities. I think we have a forcing function that is getting people expecting care, even specialty and subspecialty care, to be given closer to where they live, if not in their home. I think there's an expectation for understanding which specialists and subspecialists are thinking about value and thinking about the value in terms of their patients, not the old style of value in terms of the provider. And I think that sets us up for the kinds of experiments in scalable primary care with the appropriate information. I mean, having that primary care without the enabling information about the patients and about the potential specialists to choose, if a specialist is needed, is worthless. But the combination of the two, I think it's inevitable that we're going to continue to move ahead, in a typically inefficient way, which is our system of capitalism and our system of democracy. It's going to be inefficient, but I think we're going to continue to move ahead. David?
I think, Glenn, you really touched on it. We've traditionally had a hospital-based centered approach to care, and the idea of scale has always been buying other hospitals, merging. And, two ways to think about the inefficiencies that really have occurred because of that is, number one, often as physicians, we say we want to practice evidence-based care, but what we see in this country is reimbursement-based care, not evidence-based care. And so the idea of hospitals merging is often fraught with the idea that, well, we'll get more under our umbrella, but that gives them more market clout. And so ends up that in this world of reimbursement-based care, it just drives prices up, right? It doesn't really create the efficiencies that are often given as the advantages of doing that. We're in a new world now. And we have this internet, we have this cloud, we're seeing dramatic improvements in that. The pandemic helped to force a bit of function because we learned that we could do what we're doing right here, is we could deliver care in people's home where they are very efficiently. And most physicians are saying, hey, wow, this is much better for me. I'm learning to relate with this new telehealth. We also see that the ability to bring data together and connect smaller primary care practices, many primary care practices are small, they're in the community, they have relationships in the community, but we can now connect them all as if they're one. So think about Uber, right? Uber connects riders and drivers. It does it at massive scale. Can we connect the three entities in healthcare that are so paramount, which is the physician, the patient, and the issue of taking on risk, excuse me, really includes the care manager. So then how do we use data to have everybody operate on the same page, start to stratify patients based on their risk, and have the three of them, the patient, the care manager, and the physician, work together to help to manage care with insights generated from that common data set, and do that at the kind of scale. It's more complicated, which is why it's been delayed, but do that at the kind of scale that you see Uber or Lyft doing. And I think that's the world we're quickly heading toward, and we're excited about it.
Yeah, let me modify one thing you said, David. Healthcare is a lot more complicated than the Uber analogy, I believe. I think everybody's going to get sick. I mean, that's just it's a reality. We're all going to end up at some point with a medical issue, or our loved ones are, or what have you. And I do believe that, as opposed to the Uber and Lyft analogy, a long-term, the ideal would be a longitudinal relationship, a long-term relationship that can help an individual like me really sort through the information. Because as we all know, we're at a stage where the ability to access information and misinformation is almost infinite now. And the use of that information and the sorting through is a very important aspect of healthcare and the optimal use of the information to achieve optimal outcome in maintaining health or getting health care when it's needed. And I just believe, and this may be anachronistic on my part, but I just believe that a longitudinal relationship, ideally with a primary care physician that understands my values and may actually live in my geography, surrounded by all the input, cultural and demographic input that we would share, that would be the optimal. Plus having the information, and that's what we tried to accomplish when I was at Geisinger, and that's why I'm associated with you guys right now, because we're trying to scale that beyond the very unusual environment in central Pennsylvania.
I'm just sitting here thinking how grateful I am that we have the opportunity to hear from both Dr. Steele and Dr. Nace on this incredible topic, and to just witness the exchange between both of you as you're helping to tease out for us as well, for our audience, but really for your companies that are going to spearhead this kind of a movement. It's tremendous. I guess it gives me greater confidence in knowing that the healthcare industry is in kind of at least being guided in some part by your capable hands and your vision. At the outset, when we were in the pre-interview, when we were talking, I think both of you talked a little bit about where will this change come from? Will it come from the outside? Will it come from the inside? And I think you both kind of represented a very thoughtful views on what's going to drive the change. To some of it, you've already covered here during our talk, but I'd love to understand more about that. And then, related to that, again, because it is my final question, so I'll tag on a little question, 1A and 1B, is what gives you hope that we are poised at a time in 2023 that sometime in our near future, say within 5 years, that we will succeed in really being able to see some entities pulling off the scale. But maybe, Dr. Steele, you can start, and Dr. Nace, please add on to that. Thank you.
Well, it makes me nervous when you give me a 5-year vista. Give me a 10 or 15 years, because then nobody will remember what I said. So
fair enough. Fair enough.
Terrific. I'll tell you what gives me hope. What gives me hope is the demand of our patients for a fundamentally different relationship with their caregivers. I think and I think that's terrific. I mean, I think that's the external machine that will make us change. The other thing that gives me hope is the fact that the public payer is continuing to move towards something other than fee for service. And that puts a lot of pressure on the hospital centrics, and it puts a lot of pressure on a lot of the old ways that we responded to, the need for volume as opposed to the need for, good outcome. So that gives me a huge amount of hope. And then the third thing is the enabling technology. I mean, a lot of the stuff that it kind of spooks us and makes us nervous about algorithms, in black boxes that we don't understand. I believe, and that will help us as long as it's connected to human beings. That can have a longitudinal relationship. So I'm very, very hopeful. You're not going to pin me down to 5 years, but I think within 10 years, which is beyond anybody being able to remember what I said, I think we're going to have fundamental change in terms of the ability to expand our primary care base and to determine a different population set that will be in that primary care base and how they relate to, a huge number of human beings beyond what we did at Geisinger. David?
Yeah, I'm really excited because there's so much attention being given to primary care these days. And there's so many models that are being put forth that are actually starting to drive the change. Glenn, you hit it right on the head. The government often pushes this, and the new MA growth, which is pretty spectacular. I mean, we're now well over 50%, not just over 50% of Medicare patients on MA. We're seeing some right sizing of that model to be more efficient in improving patient outcomes. And we're seeing the ACO REACH program really focused on this issue of health equity. We're seeing lots of organizations take a look at moving into primary care as a base. I mean, heck, just in the news last week, Roz Brewer at Walgreens says, we want to shift our company away from just providing pharmacies, but we want to be primary care. I mean, that's huge.
Great example.
Yeah. And, we recently saw other acquisitions too, where people were really moving into this focus on primary care. So it's very exciting to me. And the enabling technologies, Glenn, as you pointed out, we're starting to see the connection and the drive to really assess patient outcomes. and more importantly, to really leverage the knowledge that we're gaining about the impact of social, environmental, and economic impacts, and to be able to engage the patient and the community around that. So I'm very hopeful. I'm hopeful maybe 5 years we'll actually start feeling like we're getting into them.
He's putting it out there. He's on the line for 5 years.
Skeptical about a lot of the horizontal M&A, where hospital centrics get bigger by merging with other hospital centrics. But a lot of the vertical M&A out there is really pretty intriguing. And I'm sure the transactional challenges are huge, but when Aetna CVS is starting to talk to Oak and and Oak Street Health, and I mean they're trying to do what Optum is trying to do, and some of it'll work, some of it won't work, but it's going to be an attempt, I think, based on scaling different definitions of primary care and putting payer and provider together in various ways, which I think is going to be intriguing.
A question or two ago, and then a little bit in the last one, you were talking about how important that relationship is with, the human, the data, all these things. And it occurred to me that it's almost like everybody is individually blind when they're in their own silo. Because the data, everybody can say data's great, data's great, data's great. But if a provider has data but isn't working with other people to have the context from, whatever, for even payment, like you were saying before, the socioeconomic aspects of things and understanding the family dynamics. If people can't afford to have these tests, it doesn't matter who's going to pay for what. And then the patient, because they do have access to all of these things, they can go on there. And I mean, you can conjure up any disease that you want if you Google the right combination of symptoms without the context of a physician or a nurse or some other type of medical provider. Your data is not leading you anywhere but down a blind road without anything. So really,
you got it.
Have to have that connection. And so that really struck me, just how important it is to both advance so that we can scale to reach these things, because we're making incredible advancements in things and coming back to primary care and finding the value-based care and outcomes. But it's very human driven behind that data, and the data is driven behind the human. It's just one circle. It's the chicken or the egg of healthcare. Thank you guys for being here. This was a fascinating conversation. I really loved it and loved hearing about your hope for the future, whether it's 5 or 10 years. We'll leave that up for debate.
We'll take some bets though.
Yes.
Thank you so much for making the time and for sharing with us your vision for the future. It inspires us to participate in this as well. So thank you.
Thank you.
Our pleasure.
And we'll talk to you soon. Bye-bye.
Bye.